Hi, welcome to another episode of our therapist interviews with Stroke Warrior Radio. Thanks for tuning in today. I'm a stroke survivor myself, having had my stroke 8.5 years ago now. I'm sorry. It is the goal of Stroke Warrior Radio to provide information for stroke survivors everywhere, whether you've had your stroke last week or 10 years ago. Um, I'm your host today, and our guest is just drew a blank, stroke brain.
You can
You
say
want
hi,
to,
I'm Kellyanne.
Kellyanne, there you
I'm an
are,
occupational therapist.
with Evolve OT.
Evolve Occupational Therapy, that's right.
Awesome. And you're based out of New Jersey,
Yes.
which is pretty awesome since I was born and raised in Jersey. Well, welcome. I appreciate you coming with us today.
Thank you for having me.
Um, let's talk about what is occupational therapy.
So occupational therapy, it is a wonderful profession. But what we do is we work with individuals throughout their lifespan, either regaining, relearning, or sometimes just learning their tasks for everyday life following the onset of illness or injury. And I say that that's like a blanket definition, but for people who have had a stroke or a brain injury, um, we really focus on not only their ADLs, but pretty much all of the things that you do throughout your day, from the moment you wake up from to the moment you go to bed. Um, and again, not always is it just the things that you do, but I think one important thing to note about occupational therapy is that we're actually experts in activity analysis or task analysis, and we're able to break down your everyday tasks and then build them back together through skills, habits, routines, and things like that.
Okay. Is excuse me. Occupational therapy also carries with it, besides ADLs, it carries speech. Uh, there's some areas that people wouldn't expect. I've told you before about, I didn't realize I needed occupational therapy till my daughter said my handwriting was off. So would you expound on that a little bit for me?
Sure. I think it's important, again, to, look at it a little bit more globally, right? So I was thinking about this today because I'm constantly trying to provide a good definition of what we do. And I think using tangible examples is really helpful. So I was thinking of something like building a Lego the other day. Mostly, it's pretty applicable to an adult because adults are typically the ones building the Legos for the kids. And then, the kids also, it goes across the lifespan. There's a Lego for everybody, right? And I want you to think about what it takes to build a Lego, right? You have to, thinking about, let's start from the top down, your vision, right? You have to be able to see the instructions, scan the instructions, be able to look at this pile of colorful plastic and determine all of these different qualities of it, right? You have to be able to tolerate looking at something up close for a long amount of time. All of those areas can be impacted by a stroke. Next, you have to cognitively be able to do it. So follow the instructions, remember what you're looking for, remember the direction the piece is going in. You have to remember what page you're on, remember to flip the page to advance through the different designs, right? And so again, cognitively speaking, right? Your brain, going through an acquired brain injury like a stroke can be impacted in that way as well. So a lot of patients who have had strokes have issues with memory, attention, problem solving, sequencing, organizing a task. And if you think about building a Lego, it needs all of those things. And then I'd say lastly, the physical component, right? You need the fine motor coordination, you need the range of motion in your arm, you need strength in pinch and grasp. And I think one of the biggest telltale signs that people are familiar with a stroke is really the physical impact, and how you can have hemiparesis, or weakness on one side of your body, right? And as occupational therapists, we address this to remediate or to help build back the strength and the range of motion as well as the motor control. And when we can't do that, we're looking for different ways to compensate for the lack of strength and coordination. And so all of those things are needed. Back to my example of building a Lego. But if you think of it from the perspective of not only handwriting or dressing, but what's required to do this task, and then take a step backwards and say, and now what is impaired or what am I having difficulty with after the stroke? And if it's vision, if it's attention, then tying it back, or strength and coordination, and then tying it back to, something like handwriting or putting on your socks and shoes or getting dressed.
Okay. I know this sounds very simplistic and I apologize, but occupational therapy is mind, arms, fingers. Physical therapy is legs. Is that about?
So Um,
Yeah,
you
I
know,
know.
we're trying to move away from this. OT is the upper body, PT is the lower body. I think physical therapists would say that they do more than just the legs. But think they're working neurologically too. We have to think of neuroplasticity, and they're working on walking, on balance, on getting from point A to point B, transfers. They're probably the best person to ask about what they do. But we work so closely together because OTs also work on balance. We work on transfers. We work on ambulation, how it relates functionally to what you have to do every day. My PTs are my greatest, supports, along with my other disciplines as well. But the PTs who work in neuro rehab are a special brand of physical therapist because they really do value the collaborative relationship between the OT and the PT. There's room for a lot. There are certain things that we definitely specialize in. My brain does not work like a PT's. A PT's brain does not work like an OT's brain. And I think that that's important to emphasize, that the way we address a problem will come from different angles, but both angles are necessary in order to have the best impact for the patient or
Yeah.
outcome for the patient.
So the team effort's a huge thing in any therapies.
Absolutely.
Occupational therapy also carries within its umbrella, I guess, speech, ophthalmology, those kind of things as well, correct?
Well, so we would look at, we're not, I think where we overlap with speech is really in this sort of like cognitive component. And, I would say there's like a cognitive trifecta between occupational therapy, speech therapy, and then neuropsychology. And we really also work together to kind of determine the best plan for the patient. Where speech they're doing their evaluation and how it impacts their ability to process, understand, communicate, all of the information that they're receiving throughout the day. Neuropsychology kind of works together with us in that respect as well, where they're really pinpointing sort of those neural substrates responsible for the impact on the person's cognition and their speech, but also being able to help create these tangible strategies for a patient. And where OT comes in with both of these areas is that we really work on what's being called these days as functional cognition. But really what it is, it's a performance-based either assessment and treat. It should be assessment and treatment, not either or, but a performance-based assessment and treatment strategy that includes cognitive components, right? Processing, and really demonstrating how the person is able to like process and execute a task. And so we all sort of work together, and it is scaffolded. And I think that, again, it's really that comprehensive nature of rehab is really, really beneficial.
Okay.
Yeah.
One of the things we talked about earlier was I didn't know I needed a lot of OT. I don't know why. Is there a lack of information and discharge from the hospitals? What should new stroke survivors know that they need to be asking?
Yeah, this one's a tough one. I feel like um there's a lot of misunderstanding out there. I think that I'll refer to them as rehab or referral partners, right? Whether they're doctors or, nurse practitioners, who might have a different understanding of what rehabilitation entails, especially with an occupational therapist. Oftentimes, there's a patient who's been discharged from an acute medical center, and they're sent home with no referrals, right? Yet this person is having a difficult time with vision, or they're having a difficult time actually using their hand. And firsthand, accounts. We've been told the patient's doctor told them they didn't need OT because they weren't weaving baskets for a living and they didn't use their hands. But last time I checked, you use your hand to type, to open doors, to brush your teeth, to button shirts, and that has nothing to do with their work. But this person still couldn't use their hand effectively. And this referral partner really kind of missed the ball there. So I do think that there's a lack of understanding and awareness of really what our role does in the rehab team. And then I think, unfortunately, a lot of people don't know about OT unless something happens to them or to someone they know. And it's really that their sphere of influence. And if it's the way the world works. But
Yeah.
my antidote for that is really sharing information, which is pretty much what you're doing, so that people do know. And even if it's not, a new, someone, I haven't had a stroke, but maybe I know about what to do. So I can tell someone, they can tell someone else, and it spreads that way.
Yeah, it seems to me, from my experience, that the most effective treatments and recoveries come from a real open, honest, and collaborative effort. What does that look like in an effective therapist and patient relationship?
Ah, I love this. So that's also like the beauty of OT is that we really can make anything into therapy. We're not bound by protocols necessarily. We're not bound by patient has to do A, B, and C. We revolve around the patient. And I think sometimes in medicine, we can lose sight of that. And I think like a call to all OTs is really making sure that you keep the patient at the center of the treatment plan. One thing I do is I work with the patient on their initial evaluation to determine realistic and achievable, but most importantly, meaningful goals, right? So I might have someone come in here and they have weakness and in their right side, they're unable to use their dominant hand. And I might say like, okay, well, dressing, bathing, grooming as the goals, but I'm not paying attention that this person loves to cook or they love to play cards. And it's my job as an OT to come and dig that information out to really connect with the patient and make that the center of our treatment plan. I can make the goal to improve the coordination, but know that the real goal is to help them, engage in a cooking task or play cards again so that they can return to those meaningful things.
Yeah, I've talked to other stroke survivors that have. Um, One of the things one of my therapists did early on is said, "What do you want to do?" It was like the patient has to be involved in it and say, "Look, this is what I can't do anymore. Can I do that again?" Is
Right.
Yeah. I mean, what isn't that what patients really have to learn?
Yeah, I think that goes along with I put up a post the other day about like therapy is not a passive experience. So I think sometimes we have a group of patients that come in and they want, e-stim, or they see a modality and they expect therapy to be done to them. And the principles of neuroplasticity, it's really practice, but it's active. I often explain it to patients that, the thought, I can give you the activity, but and I can help you with it, but really the drive has to come from within. The fire has to be lit on that motor loop from inside your brain, and that's what's going to drive the change. It's going to rebuild the highway, rebuild the connections, and motivating, like a motivating task, something that they want to do is really, really the biggest driver.
Yeah,
We often get people too who come in and they say all they want to do is walk. Um, and that's been a definition, like one of those OT definition things where it's like, PT, it's like they teach you to walk, and OT is everything else. Or, where would you go once you're walking? But it's important for us to not accept just walking as a goal, and really help the patient understand exactly what you said, that it's, you give me, like, what was your life like? What would you miss the most if you couldn't do it again?
exactly. Exactly. I found, for me, I found my first 6.5 years was boring recovery and every aspect, OT, PT, everything, especially mental health. I found that started doing the things I used to do, whether it was, uh, you know, hammering or climbing a ladder or stuff. It was and becoming repetitive and consistent and doing those things again. It may not have looked pretty, but it started to work. It started to get better and better.
Hmm?
As so, I mean, I appreciate what you're saying, because if I didn't participate my first 6.5 years as much as I should have, and that's
Mhm.
probably why it took so long to get the remarkable recovery I have now. You know, so I thank you for encouraging people to do that. One of the things that a lot of us hear is this is as good as it's going to get between 6 months and a year. Tell me about that, your opinion about that. I know you're
Um,
familiar with neuroplasticity, so
yeah, yeah. So I was actually, before I got on here, I've been trying to make a video about this exact statement, right? And I can't squish it into short enough seconds. But I think that that's a piece of information that has been shared. Like, it is not, there is the greatest amount, okay, this is what research shows. The greatest amount of motor recovery occurs within the first 6 months following an injury. That does not translate to all of the motor recovery will occur in the first 6 months. People come into my clinic all the time and they're saying this. They're like, is it too late for me to get better? It's been 3 years since I had my stroke, or my stroke was 8 months ago, and now I'm out of that 6 month window, and I'm doing sort of damage control, explaining that, like, no, there's no expiration on neuroplasticity. You know, as we get older, of course, our brains change, our bodies change, right? Just like our bones might get a little bit weaker as we get older, our brain might have a harder time learning new things, but the learning doesn't stop. It's the neuroplasticity stays there. You can continue to get return of movement, of motor control. You can continue to get stronger. And all of this applies to returning to your functional capacity, right? Um, that's something I wish I could, shout from the rooftops, that, it doesn't
yeah,
expire, you know?
exactly. I mean, I was on a cane for 6.5, well, walker cane, whatever, for 6.5 years. Now I don't use any of it. So
Wow.
yeah, it's pretty cool. I mean, there is a hope, and statements like "it's as good as it's going to get" takes away the hope. I mean,
Hmm.
there's the mental aspect of what you do as well. I
Of
mean,
course.
your training or education includes the mental health aspect, doesn't it?
Yeah, so occupational therapists, the program that I went to, I was in a 5+ or a 4+1 program, bachelor's, master's combined. And many of us, one of the requirements is, taking psychology, multiple psychology courses. And I actually ended up pulling in more psychology courses and having it as one of my minors. But also within the OT education itself is, a big emphasis on therapeutic use of self. And that's our ability, and in our training as OTs, is really kind of pulling from our clinical understanding or clinical reasoning, of pathology and, you know, neurology, and then also combining that with psychology, right? And how we can help the patient process and build from where they are to where we know that they can get to.
Sounds great. How do people, one of the things I learned is interviewing, visiting physical therapy and OT facilities and learning about them before I decided that I didn't have to take who the insurance company recommended. What do people have to look for in a therapist?
Ooh, I like that too. Um, I think that, my biggest recommendation is probably somewhere that focuses on neuro. And I know it's harder to find. It's an issue with availability and access. But if you can find a neuro-trained therapist, that's your best bet. What you will find easily is an orthopedic, clinic, or someone who, is a generalist. And there's just different principles, there's different patterns of movement, expectations. Neurotherapists really just are trained a little bit differently. And I think that really can make the difference in someone's experience.
Right. I also found out that you can fire your therapist. I mean, if you're, it's a relationship, right? So, I mean,
It
if
sure is.
it's a bad relationship, find somebody new.
I mean, I agree. And I do agree with you. I think that some facilities, won't necessarily entertain changing therapists midway through a program. And I think that comes more from scheduling demands, than anything. I think that they do value the patient experience. But by all means, because you are, starting, if you're starting in one place and you feel like you found another place that's more accessible to you, you have every right to go, um, and continue therapy elsewhere. And I agree. I don't think people know that. I think that they are, it's twofold. It's a dynamic situation. They're a therapist that specializes in neuro rehab might be too far from home for them. And then they're seeing someone at home, but they're not necessarily addressing all of the, intricacies that occur with a neuro rehab situation. So, and they feel stuck, but
Yeah, yeah. Is that true of TBIs and those kind of things as well?
oh,
Not just stroke?
absolutely.
I
Not
mean,
just stroke. I think any neuro, so there are different certifications where you will find someone who has, a specialist in stroke rehab, right? There's different certifications that can be, um, I'm not like, you can take a course and then get this designation, right? But that doesn't mean that they only treat stroke patients. For example, I have my CSRS, which is the Certified Stroke Rehab Specialist. I also treat patients who have had concussion, TBI, Parkinson's, multiple sclerosis. But all of these sort of patients that fall under this umbrella of neurological rehabilitation, so anything involving your nervous system or your brain and spinal cord, my biggest recommendation is to find a therapist that specializes in neuro, not everything,
right.
not a place that specializes in everything, but even just a, full on neuro. And they exist. It's just we
That
have to
just
find
takes a little bit of research and work to find out.
them. Yes.
Please tell us what patients can expect for recovery time and other partial or full recoveries.
So that is the $1 million question, Ralph.
Yeah,
So, I often I get I get that question a lot. Am I going to get better? When am I going to get better? There's a few ways that I answer it. First being that I'd be a bad therapist if I'm telling you you will get better. This will occur at this point. Um, because of the way everybody's brain is different. Everybody's stroke is different. Even if you had a stroke in the same place, in your brain, our brains are wired slightly differently. And how you might be impacted might be, someone next to you might be impacted differently, right? So it's really difficult to give that sort of time frame. I do say that also, it's not even how much you put in is how much you get out. It's difficult for us to really guarantee that there will be full neurological recovery, but what we can do is really try our best to get the most that we can. And in no way am I saying it's easy. It does take effort and it takes frustration and time. And if you're willing to put that in, you will get the maximum recovery that you can. Um, but yeah, it's difficult to really give that
yeah,
that time frame.
perfect answer. What expectations are possible for recovery? I mean, it's like you just said, I want to do this, do that, and I've got a trip to go on next month. How can I do this? Is that Does that take away hope from patients when they expect too much as well?
Um, I don't necessarily think it takes away hope. But of course I'm not the patient. I'm not on that end. Um, my mantra too really is like never say never. Again, it depends on the person. It depends on their stroke and really the severity of their deficits. But I do think that there are ways around a lot of things. I think that it helps certainly to be open um, to the fact that you might return to doing something. It might not look the same. It might not be as mindlessly easy or easily facilitated, but that doesn't mean it can't be done. You might have to think it through a little bit more before you go away on a trip or something. Um, but there are people all over the world that are traveling the world, experiencing things in beautiful ways. And they're doing it, after a brain injury, after a stroke. They're doing it from a wheelchair. They're doing it with walkers, but they are doing it. And I think that that's the most important part.
Yeah, I agree totally. Um, what information do you share with patients? Well, let me ask this first. What patients should know that they don't know now? In other words, I hear all the time, we didn't know what we didn't know.
Right.
I mean, what are some of the things that we need to ask as a new stroke survivor?
Do you mean like your medical team or your rehab team?
Yeah, because in my case, the medical team, I was at a teaching school, and
Okay.
my neurologist with 35 years experience and my attendings were completely opposite. You know, the neurologist gave me hope, gave me all kinds of ideas, everything. The attendings were like, here's check this box, that kind of thing. And if I would have known better, I would have followed the neurologist a lot more detailed.
Yeah.
Um, if I would have known better, I would have asked for occupational therapy.
Hmm.
I would have asked for speech therapy because I didn't realize not having, I didn't have aphasia. But I just started going to speech therapy in the last year because I found out I have swallowing issues because of the stroke. I mean, there's so much that we didn't know, I mean, it's probably too broad a question to ask, but it's like we didn't know what we didn't know. What is that?
Well, I think that this is just something that I think there's a change that's sort of occurring. And I myself, when I've been a patient, I had historically followed everything that the doctor said and thought that that was, that was it. Okay, he did the check. I would assume he would have told me, or that she would have told me, they would have told me everything that I needed to do, right? And I think one of the big things is empowerment as the patient, and empowering the patient to stop and ask the question, even if they don't know what the question is. But really stopping and asking, what else do I need to know? There's I've never had a stroke before. No one in my family has had a stroke before. Give me a resource. Stroke.org is really helpful. There's a lot of information. It's a lot to pull through and can really be overwhelming, but having something like that that can help you understand that, what may have caused your stroke, what can you do to reduce your risk for a stroke again in the future. um, I do find that the education is lacking in that respect. I think that yeah, there's definitely room for growth there. But you're right. You don't know what you don't know. And I doubt that 100% of patients are like you and find out eventually that there's like services available to help them. Um, but I really do think if people are more empowered to stop and ask the question, like, what can I do to help this? Or, even a follow-up appointment with the neurology team. What can I do to get better coordination, to hold my pencil better, to, tolerate reading on the computer more? And it works on our end too. I've been a therapist for 14 years, and only in the past year and a half have I started to really push and say, like, I've got to share this information with people because no one else is doing it. Um, AOTA is doing it. Our boards are doing it, but really that sort of like grassroots, ground level, micro influence, person to person. I think that that's really some of the best, best information we can provide and share,
Yeah.
to help people
Um,
understand.
I, that kind of leads me to the next question. What you said, how do you see the growth of stroke neurological therapies and practices in the future?
Ooh, that's another good question. So, you know, the hard part is that the medical system is always changing. Um, they're they want more with less time given to each person. And I think that therapists are really going to have to reinvent themselves, and the way that they provide care in order to help the patient have the best outcomes. With that, I also think that major hospital centers and bigger therapy systems, are going to have to reinvent themselves, because people are getting older, they're living longer. As you get older, your chances increase for stroke, and for every other neurological condition. So, and medicine's constantly getting better. People are surviving strokes. They're surviving and living longer after having a stroke. So, more people are definitely going to be in need of rehab and therapy, as time goes on. So, um, the field should continue to grow, but as it does, we're going to have to, I'm sure we'll have some growing pains, but,
Yeah,
um, you know,
yeah. Well, I think the awareness too is a big deal right now because, we know so much about heart attacks, the signs of a heart attack, and that kind of stuff. Nobody knows about BFAST.
no,
Not as many people should have that should know it.
right.
It's the balance, the eyes, the
Hmm.
face, the arms, the speech, time to call 911. I mean, it's it's a growing conundrum, I think, that it's a lack of information on both sides. A lot of therapists don't have strokes or no strokes,
Mhm.
just what they've learned in school. But in your case, you've got 14 years experience. You've learned firsthand what works and doesn't work.
Mhm.
Um, what do you, I'm always interested in why people get into the careers that they do. What inspires you to do this?
So I actually wanted to be a PT first. And I share that with people all the time because I feel like I'm the most OT that I know. But actually pretty much everybody I work with is the most OTs that I know. We're all pretty passionate about what we do. But I wanted to be a PT first. I started school in the DPT track, and then I got into it and it was very just not for me. I loved learning the kinesiology. I loved learning the anatomy and all of that, but I didn't get to the DPT part. But it was just much more like biomechanical for me. And I knew there was a neuro component, but I wasn't necessarily into that part of it.
Yeah,
And then I learned I really didn't know that much about OT. I had the wrong understanding of it. I really thought about it as just working with kids. And then I read a few books while I was exploring. I worked with my counselors at school, and you know, I took like a year to kind of reflect, and I just worked on like core curriculum stuff. And I ended up deciding that OT was it. I read books about, Jillian Bolte Taylor, Dr. Jillian Bolte Taylor. She's My Stroke of Insight, um, In an Instant by Bob Woodruff, who had a traumatic brain injury while he was reporting overseas. Um, oh my gosh, Where's the Mango Princess? There were so many books that I read,
wow.
and then continued, just going through these things. And that's what really spoke to me. It was, I think part of me, wanted to help people see that they could do more than they thought they could. And I think that's a big component of OT. And I loved to see the change and the growth in people in these stories. And they're not made up stories, they're real, people, real situations that overcame extreme adversity to, you know, regain function and go back to living their lives in the greatest capacity that they could.
Yeah, yeah. Um, so tell us a little bit about Evolve Occupational Therapy.
Okay, so Evolve is the brainchild of my doctoral project. So after being a therapist for about 12 years, I decided to go back and get my doctorate. So I just finished my OTD about, oh my gosh, a month or so ago. And my project was titled Evolve OT. But what it is it's an alternative model of service delivery for adults with neurological conditions. My research found that there were so many people referred to OT that did not complete the referral process. So they didn't transfer or convert from referral into an actual visit. And so what I did was I wanted to find out why. And what was found through both like a little bit of interviews with patients, but also a literature search, is that there's issues with awareness, availability, and comprehensive affordability of care, right? So what we have been talking about, that people are unaware of what OT is, the scope of what OT is, and the role of our profession. And this is amongst patients, referral partners such as doctors, nurse practitioners, and other rehab providers, and the community as well. So that's the first issue. The second is, availability. Neuro clinics exist, but when there's, 60 neuro clinics to 10, or 60 orthopedic clinics or general clinics to 10 neuro clinics, those are going to be easier to find. And furthermore, they're further away from people. There is a big issue. I think about myself working and having a family, and managing all of those things and trying to get to this specialized center, you know, as OTs, like I said before, you know, really want to lean into this alternative model of care. It doesn't always have to be in person. You know, it doesn't have to be 2 times a week, every week for 6 weeks. We can be flexible in how we provide care, but also where we provide care. And that's the whole concept behind Evolve OT, is building a program around the patient so that their needs are met. You know, I offer in-home therapy, I offer therapy in the community, I offer telehealth, so that a person who might not be able to get to a clinic otherwise would be able to get there
Wonderful.
because I'm getting
Wonderful.
there.
That's very cool. I wasn't aware of the issues with referral to actual practice. That's amazing. Anything you want to add to our discussion?
I mean, I think I said it all and more.
Yeah,
But this is the mission of, you know, one of the missions of OT, of Evolve, my program, Evolve OT, is to share what OT is, you know, and like how it has helped people. And in the short time that I've had this operation running, I've learned so much about how much people don't know. You know, just in asking questions and posting questions and who is answering them and how they're answering. It's funny, of course, it's like my own family who's answering questions the wrong way. And I'm like, you know this, I talk about this all the time. But
yeah.
you know, I think the more of us out there, the better. And it can only, you know, we should use the internet for its benefits to share, positive information, hopeful information, and most importantly, you know, real information so that it can help somebody get better.
Somebody told me a long time ago, the only dumb question is the one you don't ask.
Absolutely. Yeah.
I mean, if it comes in your head, ask it.
Yeah, absolutely. And I
That's
think, yeah,
yeah. It's if I didn't ask the silly questions like, "Am I going to be able to climb a ladder?" My therapist brought in a damn ladder to the session so I could
no,
start
exactly.
practicing. Right.
Exactly,
You know,
exactly. And you know, I think that just a message for therapists is that we can't assume that everybody knows what we know. And I think sometimes we have major imposter syndrome because unfortunately we are like looped in with other disciplines. And so then we think that everybody just knows what we do, or the opposite, that nobody knows what we do. And I think it's important to like get away from these definitions that are silly and ridiculous, but really share the content of what we do. You know, we help people break down the areas that are causing you difficulty. And as humans, right, with brains, our brains are going to work to make things the most efficient, you know? But if you don't use it, you lose it, right? So it might be the most efficient way to brush your teeth is just use your other hand, but we're here to help you kind of take that step back and allow you to get frustrated, to build the skill back, to help you incorporate the other side, you know, to drive that neuroplasticity. Um, you know, I do think therapy is obviously, I think it's so beneficial and necessary for everybody, but I do think you have to be ready and willing to, you know, get down and in there and to get frustrated, you know, to build back those skills, to get back on the ladder, to climb back up, to work on the balance and get there.
agreed. Kellyanne, thank you so much. This has been an incredible interview. I really appreciate all your input. You can find Kellyanne Ornella at evolveoccupationaltherapy.com. Is that correct?
That's correct.
And you're also on Instagram, I think.
Yep.
What's the
Yep.
Instagram handle is?
Evolve Occupational.
Okay. Thank you very much. You have a great day.
Thank you so much. You too.
All right. Bye bye.
Bye.